like to invite Dr. Andrew Stalman for his talk on revision ACL reconstruction review of the registry.
Thank you very much. Thank you for inviting me again. I was here 2 years ago and had a great time, and it's great to be back. I was asked to talk a little bit about revision surgery and what we know from the Swedish and Scandinavian registers. So if you look at the literature, you get the impression that most revisions are due to technical failures. About half of the patients or more are due to technical errors or mistakes done during surgery. And that's indeed, I have these cases as well. Most often we see problems with the femur tunnel. Either it's put too anterior or it's put too high. So I would advise you to be very precise with measurement and placement of a femoral tunnel, because that is a problem. And we see all kinds of revision situations with wrong positioning of tunnels, like this tunnel that's very low, and the bottom there is obviously in the wrong place. And here you have a tunnel that is too far back. But with that said, I must say that most of my patients that come for revision surgery have had a new trauma, and the initial surgery was well done, like in this case. And with a good surgery, the revision will be very easy as well. I almost always do one-stage revision. In most patients, the tunnels are okay, and we don't see significant tunnel widening anymore. And it's almost as easy as a primary reconstruction. And if it's, so most often the tunnels are good enough, or it might be bad enough, and then you can put new tunnels beside the old tunnels or underneath. If it's not good enough or not bad enough, you can still quite often do one-stage revision. You can drill the tunnels a little bit larger, more eccentric, or you can try to use larger grafts. But there are cases where one stage is not possible, or if you're afraid that your tunnels will conflict with each other, you can use these blocking screws to protect the whole tunnel in case of a conflict. But when it's completely impossible, you need to do two-stage surgery. That is most often in cases with tunnel widening. We saw that more often before, but with the modern screws we have today, I almost never see it anymore. But in my experience, if you have an MRI that shows tunnels wider than 12 millimeters, you should be prepared that you might be able to not be able to use it, and you might need to do a two-stage revision. What I do then is that I take the crystallica graft, or maybe allograft bone if I have access to that. And I use dowels like this that I put in the tunnels. One in the femur and often two in tibia. I do a CT after about 3 months, and if it looks good, I plan for the second surgery. So what I do when I do revision surgery, I always start with doing an arthroscopy, evaluating the tunnels, remove all the hardware, graft remnants and sutures, and then sequential reaming of the tunnels until I see fresh bone, and then I know the size of the tunnel, and I take a graft that can match that size, and if I can't, I might have to do a second surgery later on. So then to the registers. What do we see in the registers? We have done multiple studies from the Swedish and Scandinavian registers about revision. If you look at risk factors, it's very obvious that you have a young, active patient. So no surprises there. If you look at the register and data on reasons for revision surgery, you see that graft position and problems with surgery, that is a reason, but it's not that common. New trauma is the most common reason for graft failure. Another thing that we see that's very important to know is that time from surgery to return to sport is a crucial factor. The study from the Swedish register shows 7 times increased risk of a re-injury if we go back to sport before 9 months after surgery. Persistent laxity, that's a problem. And we've done multiple studies looking at the risks for persistent laxity. And we see that again in young patients where we use the hamstring tendons, or if you have a medial meniscus resection. And hamstring tendons is a problem because you will have twice the amount of patients with the persistent laxity if you use a hamstring compared to a patella tendon. And also you can see in the registers that the hamstring tendon patients have a very much higher risk of revision. And we don't have any peroneus tendon surgeries in Sweden almost. So with that said, should we stop doing hamstring tendon ACL reconstruction? Probably not, because there are also risk factors for bad subjective outcome. And if you use the patella tendon, you will have less satisfied patients in many cases. So the hamstring tendon is still a good option for most of our patients, I would say. But if you have a patient with a high risk of revision surgery, you should consider doing something else. And what about outcome after revision? What happens to the patients? The registers shows clearly that if we do revision surgery, we will restore laxity. The patient will have a stable knee again, but they will not be that happy with the knee. It has a significant worse subjective outcome compared to after primary surgery. And actually, most of the patients, they don't improve at all. So the prompts before revision surgery is the same as after revision surgery. So that's important to remember. So the take-home messages here is that most revisions are simple to perform and due to a new trauma. We see technical errors. In most cases, the tunnels are wrong on the femur side, too anterior or too high. Most often we can do one stage. The tunnels are most often good enough or bad enough. But you should prepare yourself for a two-stage revision surgery if you have significant tunnel widening in MRI, more than about 12 millimeters. Consider it safe not to early return to sport. In Sweden, we nowadays often say 9 months, depends on the sport you're going back to, but at least 6 months and most often 9 months. You should individualize choice of graft. I know that you use a lot of peroneus longus tendon, and there are not that much research about that. But hamstring is a common graft in Scandinavia, and you have higher revision rates, but a more happy patient. Outcome is good regarding laxity, but limited subjective improvement. And maybe not doing revision surgery if the patient really doesn't need it. So, thank you.